If you are over 65 and you have ever sat in a doctor's office watching the nurse write down your blood pressure reading, you have probably heard a version of the same thing. That number needs to come down. Or we want to get you below 130 over 80. Or simply, your pressure is a little high and we should talk about medication. And if you're like most seniors I speak with, you accepted that. You trusted it. You went home and you either started a new pill or you pushed yourself to cut more salt, walk more, worry more because the message you received was clear. Lower is better. Get that number down, full stop. Here is what most seniors are never told in that same appointment. That framing lower is always better is not only incomplete, for a meaningful percentage of adults over 65, it is actively wrong. And the research supporting a more nuanced picture of blood pressure in older adults has been building for years in major cardiology journals, while millions of seniors continue to be managed under targets that were never designed with their specific physiology in mind. I'm Dr. Ibrahim Khan. This channel is dedicated to giving adults over 60 the evidence based health information that a 15-minute appointment rarely has time to cover. Subscribe if you haven't already, because today's video could genuinely change how you understand your own blood pressure numbers and the conversation you have about them at your next visit. Let's start with the number itself, because there is enormous confusion about what blood pressure readings actually mean. And that confusion is costing seniors their health in ways that cut in both directions. Your blood pressure reading has two components. The top number, systolic pressure, measures the force your heart generates when it contracts and pushes blood out into the arteries. The bottom number, diastolic pressure, measures the pressure in your arteries between heartbeats when your heart is at rest and refilling. For decades, the clinical focus in general medicine was primarily on diastolic pressure. Textbooks from the 1970s and 1980s treated an elevated bottom number as the primary marker of cardiovascular risk. Then the research shifted, and by the 1990s and 2000s, systolic pressure, that top number, became recognized as the more important predictor of cardiovascular risk in adults over 50. This is where something called isolated systolic hypertension enters the picture, and it matters enormously for seniors. Isolated systolic hypertension means the top number is elevated, typically above 140, while the bottom number remains in a normal range. This pattern becomes increasingly common with age for a specific physiological reason. As we age, the walls of the large arteries gradually stiffen and lose their natural elasticity. Younger arteries act like flexible tubes, absorbing the force of each heartbeat and smoothing the blood flow. Stiffer older arteries cannot absorb that force as effectively, which drives the systolic pressure higher. This arterial stiffening is a natural biological process. It is not identical to the kind of hypertension that reflects chronic cardiovascular damage in younger adults. And critically, treating it aggressively with the same targets used for a 45-year-old introduces a set of risks that are unique to older physiology. Risks that most standard blood pressure conversations completely skip over. Let me tell you about the single most important clinical study on blood pressure targets in older adults, because it is the study that changed how thoughtful cardiologists and geriatricians approach this question. And yet its nuances almost never make it into a routine primary care appointment. The SPRINT trial, the Systolic Blood Pressure Intervention Trial, was a landmark federally funded study that enrolled over 9,000 adults at elevated cardiovascular risk and compared two blood pressure targets. One group was managed to a standard target of systolic pressure below 140. The other group was pushed to an intensive target of below 120. The headline result was dramatic. The intensive group had significantly fewer major cardiovascular events, heart attacks, heart failure, strokes. That result was so compelling that the trial was stopped early, and within months, the American College of Cardiology and the American Heart Association updated their guidelines to push target blood pressures below 130 over 80 for most adults. That is the guideline driving millions of prescriptions today. But here is what the headline missed, and this is the part your doctor may never have discussed with you. In the SPRINT trial, The intensive treatment group also had significantly higher rates of serious adverse events. Acute kidney injury was 50% more common in the intensive group. Dangerous electrolyte abnormalities, particularly low sodium and low potassium, were elevated. Falls requiring medical attention were higher. Syncope, sudden loss of consciousness, was more common. And in the subgroup of participants who were older and more physically vulnerable, the trade-off between cardiovascular benefit and these serious harms became far less favorable. The researchers and many subsequent commentators noted clearly that the sprint results should not be applied uniformly across all patients, and that in older, frailer adults, the individualized risk-benefit calculation is fundamentally different from younger, healthier participants. Yet, the simplified guideline get below 130/80 became the default message delivered to millions of seniors regardless of their individual circumstances. Now, let me explain the physiological reason why pushing blood pressure too low in older adults creates a specific category of danger that most people have never heard of. It is called the J-curve phenomenon. When researchers plot blood pressure against cardiovascular outcomes across large populations, the relationship does not look like a simple straight line where lower always means better. It looks like the letter J. As blood pressure rises, risk rises with it. That part most people understand. But at the lower end of the curve, as pressure drops below a certain threshold, risk begins to rise again. There appears to be a floor below which reducing blood pressure further starts causing harm rather than preventing it. The most clinically significant expression of the J curve in seniors involves diastolic pressure, that bottom number. Multiple large studies have found that diastolic pressure below approximately 60 to 65 millimeters of mercury is associated with increased risk of cardiovascular events, cognitive decline, and organ damage in older adults. Here is why. Between heartbeats, when the heart is resting and the diastolic pressure is being maintained, the coronary arteries, the vessels that supply blood to the heart muscle itself, do most of their filling. If diastolic pressure drops too low, the heart muscle receives inadequate blood supply during that critical resting phase. In an older adult whose coronary arteries may already have some degree of narrowing, a diastolic pressure of 58 is not just a number on a cuff. It may represent genuine ischemia, insufficient oxygen delivery to heart tissue happening silently with every heartbeat. A major analysis published in the Journal of the American College of Cardiology found a clear J-curve relationship in elderly hypertensive patients with significantly elevated risk at diastolic pressures below 60. Yet, the standard blood pressure target conversation in most clinical settings focuses almost entirely on the top number and says almost nothing about how low the bottom number is being pushed. Let me now address orthostatic hypotension, because this is the blood pressure issue that most directly threatens the independence and physical safety of seniors, and it is profoundly under-recognized in routine care. Orthostatic hypotension means a significant drop in blood pressure that occurs when you stand up from a sitting or lying position. In practical terms, it is what causes that brief dizziness or unsteadiness you may feel when you rise from a chair. The momentary sense that the world tilted sideways before your circulation caught up. In a 35-year-old, that sensation lasts 2 seconds and is forgotten immediately. In a 72-year-old, that same phenomenon is a fracture waiting to happen. Research consistently finds that orthostatic hypotension becomes more common and more pronounced with age for several reasons. Reduced baroreceptor sensitivity, slower circulatory compensation, reduced blood volume, and critically, blood pressure medications that lower resting pressure and make the orthostatic drop larger and more sustained. Hip fractures in adults over 70 carry a 1-year mortality rate approaching 30%. A medication-driven fall is not a minor side effect. It is potentially the beginning of a cascade that ends independence. Yet, when blood pressure targets are set and medications are titrated, the orthostatic behavior of blood pressure, what it does when the patient stands up, not just when they are sitting quietly in the exam room, is rarely systematically evaluated. So, what is the right target? This is the question at the center of everything. And I want to give you an honest answer rather than a simplified one. The truthful answer is that there is no single ideal blood pressure number for all adults over 65. The optimal target depends on a constellation of individual factors, including age, the presence or absence of established cardiovascular disease, kidney function, cognitive status, fall risk, frailty, and the specific medications being used to reach any given target. What the current evidence does support is this. For adults between 65 and 75 with good functional status and no significant frailty, a systolic target in the range of 130 to 140 is generally supported by the research, with the understanding that the benefits of more intensive control need to be weighed against individual risk. For adults over 75, and particularly for those who are frail, have multiple medical conditions, or are at elevated fall risk, a systolic target of 140 to 150 is increasingly supported by geriatric medicine specialists as the appropriate individualized goal. This is not permissiveness, this is precision. Here is exactly what you should do before your next appointment. First, find out what your diastolic pressure has been running. Ask your doctor specifically what your bottom number averages and whether it has been consistently below 70. If your diastolic is regularly below 65, that needs an explicit conversation, not a reassurance. Second, purchase a validated upper arm monitor and take readings twice daily for 2 weeks at the same time each day. Sit quietly for 5 minutes first. Take 2 readings. Record the average. Bring that log to your appointment. Third, ask your doctor directly what target is being used for you and why. Ask whether it accounts for your age, fall risk, and kidney function. You are entitled to that specific answer. Fourth, if you experience dizziness when standing from a chair or bed, report that explicitly. Use the phrase orthostatic hypotension. Ask for a standing blood pressure test measured sitting, then again within 2 minutes of standing. That test can reveal a dangerous medication-driven drop that would otherwise go undetected. Fifth, if you are over 75 on a target below 130 systolic and experiencing unexplained fatigue, brain fog, or frequent dizziness, ask whether the intensity of your blood pressure management could be a contributing factor. That question is medically legitimate and supported by current geriatric research. Margaret was 78 when her cardiologist pushed her systolic target below 130. She had been stable for years around 142. Within 6 weeks, she had fallen twice. Home readings showed her diastolic sitting at 58. Her standing pressure dropped over 25 points within 90 seconds of rising from bed. Her doctor stepped back the medication. The dizziness resolved. She resumed her walks within 3 weeks. Her cardiovascular risk barely changed. Her safety changed completely. Managing blood pressure after 65 is not about chasing a number. It is about understanding what your individual physiology needs. The research supports nuance. You deserve nuance. Comment below with one of 3 responses. Comment my numbers to share what your pressure has been running. Comment getting clarity if you are bringing these questions to your next appointment. Or comment overtreated if you suspect your management is affecting your energy, balance, or daily function. I read every comment personally. Please share this with anyone over 65 managing blood pressure who has never had this conversation. I'm Dr. Ibrahim Khan. Subscribe now. Next week, I'm covering the blood test results that predict kidney damage from blood pressure medications years before symptoms appear.